So we do have questions here. The way this is going to work is we do have some questions just in case you all need time to think of questions. But I know you guys, you have questions. Don't be afraid. Don't be shy. But we do have some starting questions to warm us up. We may not even hit all the questions depending upon all of you. And really, this is your chance to pick their brains, you know. And that includes Annette, Guam, to ask about, you know, real life experience. So let's see, which question shall I? Oh, and if you, the mics are all both up here now? Well,
there's one in the middle.
I guess what we'll do is, there's one in the middle, so if you want to come up to the mic in the middle and ask your question, or if it's going to take too much time, I'll try to hear the question and repeat, or one of the speakers will repeat the questions. So, let's see. Oh, I think this has come up a lot. I know I've heard some of the hospitals talk about this, but so for the panel, who develops protocols in your facility? For example, PPE, transport, et cetera. Who gets tasked with that? Who gets the lovely responsibility? Anyone?
All right. So the way that we've sort of worked through the protocols is that there are certain protocols that are very nurse-centric and probably have limited risk to other people because they're tasks that nurses do or other frontline caregivers do. But something like PPE is a very high-risk proposition and one that needs to have formal vetting by your entire team. So for us, PPE really was all about starting with something, and that's evolved, like John and others have said, over the last 10 years for us with constant tweaks here and there. But we actually sometimes convene small groups. So if we have something from a standpoint of management of a ventilator, with somebody who's got an airborne type pathogen, then we may convene a team of our respiratory therapists with a couple of our ICU nurses to work through that. So it's really based on who has got the core expertise, but also then certain policies need to be run through our leadership committee as well. For final vetting or formal vetting prior to approval. So I hope that helps. So sometimes it's started by our nurse lead in the unit just to get it started and put a structure to it if it's a brand new protocol or a procedure, and then basically pulling in the content experts, and then based upon kind of risk, then we may take that to a more formal process of assuring that all of the staff are involved in looking at it, but most likely also leadership as well.
So for us, it follows a very similar process, except it's started by the person who is the most obsessive compulsive, and then she passes it around to the rest of the group, and we make comments and edits, and then it gets finalized. But you know, if she didn't take the lead, it probably, and relied upon those of us who are not very obsessive compulsive whatsoever, it might never happen.
From the public health side, it would be our Public Health Emergency Preparedness Program. However, they do pull in our nursing bureau, our community health center administrator, as well as the different categorical disease programs for any type of protocol or SOPs. So we all have our input and review. By luck, because immunization deals with mass vaccination, we got to get the mass dispensing because of the experience, and so we were able to we were responsible for drafting that, and so it is again a collaborative effort, but again being reviewed by our nurse administrators and then our medical director before it's concurred by our director.
And I just want to add that we have made all of our protocols available both through our website at Emory, and then we've migrated, I think, for most part, over to needtech.org. And so I encourage you not to reinvent the wheel, to go in, pull it out, edit it so that it's useful for your institution.
I think what I'm hearing, and you're probably hearing as well, is that it's a team thing, right? Protocols don't happen from one person. And what I noticed just listening is that each of these teams incorporates the user, right, experts, but also the administrative sort of hierarchy that has to pay for this and make it actually happen. So including that triumvirate of, you know, thoughtful people, payment people, and user people, and they can overlap, but trying to do it without that combination means you're going to get stuck.
No questions yet from the audience? By the way, if you see them winding down and you want to ask your question, get it inserted in, go ahead and stand at the mic and we'll see you, or start waving your hand and I will call on you. So barring that, I'm going to insert my biases. Infection control issues regarding the delivery process, so deliver for obstetrics. You know, what are the considerations that you all have, you know, built into your processes, you know, in terms of, now you say the scenario is you've got an infected mother and you know the baby's infected, so you've got two. What all happens there for you guys?
Shelley wants me to respond.
Wasn't that your breakout session?
Yeah. Yeah, but they want to pick your brains.
Once again, I'll say we have those protocols. No, we do have those protocols on etech.org. But you know, as you know, deliveries are A, bloody, and B, a lot of fluid, especially if it's vaginal. And so the OBs actually are pretty good about putting up collection devices that collect or catch a lot of that fluid. But essentially, we would put our OBs in the same PPE that we would use at the high level, including possibly PAPRs. I think the only thing we might do different is those boots that come up to the knee, just in case there is a lot of fluid on the floor. And then we would essentially have to go through a cleaning and a decontamination and move the patients, hopefully now, from the delivery room to our care room or isolation room. And so for us, that would be, we would separate them. I'm not sure what Nebraska would do, but the mother would come to our unit at Emory, and then the child would go across the street to Children's Healthcare of Atlanta, which is our partner and regional Ebola treatment center. But so for here, I guess you would be lucky that they would both be at, I don't speak Hawaiian very well. Kapiolani, is that it? Is that close enough?
Kapiolani.
Okay, all right.
Potentially.
Yeah.
We'll never know where that's going to be. And our process is very similar, but both the baby and the mom would come to us. But we really worked out with our OBGYN staff and our NICU team. They've done training, and you know, we have a core group of physicians who said that they would be willing, and so we do PPE training with them on an ongoing basis, and really just kind of work through a process of how it would all go, so I can share that process map with you guys as well. And then we would move after delivery to the biocontainment unit. So we thought, you know, it would be best for people to be in kind of their own comfortable area. And plus, if you don't know if it's, you know, a PUI at that point, you really don't probably have the luxury of having some of those diagnostics back yet. So you have to just take all the precautions while you're working through that, and then, you know, go accordingly based upon the outcomes of that. So.
I'll add a couple of things that are just a reflection of a recent experience in another state where planning had to be undertaken for somebody who was a person who recovered from Ebola who was going to deliver a baby. First of all, the staffing overlap of obstetrics staff, especially nursing, is not likely to be 100% with the people who are thinking about isolation and containment units. And so figuring out what that balance should be and recruiting the right people, again, as sort of the experts, the doers, you know, these are people who are going to have to inform the process. In addition to those folks, anesthesiology for spinal anesthetics, epidurals, environmental services who need to be ready to deal with the mess in a very different way than usual. This is something that concerns me personally, that the normal obstetrics, even high-risk obstetrics practices, tend to be pretty comfortable with exposure to body fluids. in a way that probably creates some habits that you wouldn't want to see for something as high risk as this. And so talking through that with environmental services and nursing staff, I think, is going to be critical. The other piece is communications. The amount of fear that can be created by this is significant, so that's the same as always. State health department involvement, it would already be there, but when you think about why, it's also because moms have to be somewhere before they go into labor. And you may not want to wait until the last minute to get them to the hospital or to contain them. Are they going to stay in the containment unit the whole time? Are they going to be lodged someplace nearby? That piece is also worth thinking about in advance.
Okay. By the way, I will field questions too for the health department if you have that question. Really for them. Go, good, yay.
In regards kind of to the whole fluid management, I mean, you were talking earlier, the person might have like 8 liters of stool. I was wondering, especially with person being hypovolemic, possibly no longer mobile, in those places, would you guys try like the fecal management system or anything like that? Was that?
Yeah, absolutely. So that question was asked on 2 separate occasions right after my talk. So we had a nursing policy in place that did not allow for bowel management or fecal management systems in conscious patients. So we told them that they needed to rewrite that policy post-haste because it was way too much for our nurses to handle. And so we did. We inserted rectal tubes in 3 of the 4 patients. So, yeah.
We did the same. Any questions?
So before that, we moved successively. So most of our patients wanted to try to use a toilet. And so it's maybe 10 feet from the bed to the toilet in our unit. And then as they got more dehydrated and more pre-syncable, we made them use a bedside commode. And then things started hitting the floor that shouldn't be on the floor. And that's when we made them stay in bed and placed a rectal tube. So.
Okay. I'm actually going to insert a question that, just to bring up a point that I remember hearing Marshall bring up that I don't know was brought up with all the other hospitals, because you had mentioned that at one point you had one of your patients who was quite large almost fall on one of your nurses. So it was a near miss of a potential injury, not only an injury to the nurse, but also potential for more contamination. So just question is, having had that experience, and even if you haven't had that experience in Nebraska, I don't know if you've had, what kind of measures have you put in place to sort of evaluate safety of the healthcare workers, or even, you know, there was a picture on one of your slides, I'm forgetting whose, maybe it was John's, or where, yeah, I think it was yours, it was healthcare worker down. You know, and those, you know, those that PPE gear, you know, no matter what, maybe you just didn't eat enough yourself, and you didn't hydrate enough, and you have a vasovagal reaction, and you pass out, and what if you hit your head? That kind of stuff, or you just collapse there, and now you've got someone in there. So if you can talk to some of the measures in place to assure the healthcare workers are monitored for their own safety, and how you can get them out of that situation.
So for us, that was one of the reasons, and we had already had this in place, that we always had our ante-room nurse or our observer nurse at near ready. So it was in complete PPE, except for putting on the PAPR hood. But the PAPR hood was ready to go, was pre-sized, battery checked, battery, you know, the nurse was wearing the battery so that they could get into the room in under a minute, and a lot of times it was actually less than 30 seconds that they could get into the room to help. Whether, you know, it's in that scenario that you just mentioned where the patient is syncable or the healthcare worker is unconscious. So that was why we had that policy. Trying to think if there's, so we did, as our patients, as I just mentioned, not only from a stool standpoint, but becoming syncable or pre-syncable, you know, I had to actually talk with our patients and convince them that they were becoming a danger to themselves and that they needed to learn to use the bedside commode, or they were going to be confined to bed until that they were not that way. And they understood. They weren't happy about it because everyone was very modest, and no one really, I mean, you've got people, someone's in the room with you, someone's watching the entire time, your family members are coming in, you don't really want to use a bedside commode with no privacy, but we just said, you gotta, sorry. So.
Very similar processes. We always had a second person in full PPE so that they could quickly intervene. We had our video telehealth system on constantly, so anybody who was out at the desk could be visualizing the caregiver and others in the room to see if there was anything starting to evolve. Certainly during certain cares, that second person did come in and participate and support, and then we talked a little bit about, we did a drill, a man down kind of drill, so that we could work through all the logistics of getting somebody safely out of their personal protective equipment and doing it in a very timely fashion. So that protocol is available too if any of you, because I'm sure the concepts would be very similar. For all of you, it would just be a little bit different geography that you'd be working through the logistics with in your organization. So I think the other thing is this is a team that raises the flag very quickly on a lot of things, whether they're seeing somebody else perhaps that's doing something that could be a danger to themselves. I think they were all, but we reminded them to make sure that they hydrated it and they ate before they went in for their shift, and certainly the age-old process of anybody who's run an operating room before is using the wall and sitting down if you feel a little bit weak, and then working through the process as well to help them get out safely. So.
Okay. Anyone else? Okay. Kind of related to, I think, oh, sorry.
Hi, Dr.
Okay, go
Park.
ahead, John.
Wait.
I guess Mike had a...
Is there ever any role for sedation and anxiety, that kind of thing?
Absolutely.
Yeah, so you can calm.
You mean for the patient?
Yeah.
For Marshall?
I was excited there too for a minute. Mike, we're going out tonight.
Yes, there absolutely is a role for that, and we didn't. Well, we did actually. So I mentioned this in my breakout session, at least, or something yesterday. Sorry, time is blending together, especially when you're 5 time zones off from your normal. Our patients did become delirious, which sometimes was funny. One time was scary when the same very large, very strong man reached up under the shroud of the PAPR with his hand around the neck of one of our male nurses. And so yes, we did use sedation to calm things down. Yeah.
And so we experienced that as well, and it was actually in the pre-hospital environment. So one of our patients became quite delirious in flight to us. And as it was explained to us, if the Phoenix Air isolation unit had been constructed with any better of a zipper, the patient probably would have made it out of isolation. So, but the patient was delirious and was trying to remove themselves from the isolation unit, and they were just weak enough that they couldn't get through the zippers to get out. Yeah, so at that point they moved to a chemical sedation. And also, fun little anecdote, at that point Phoenix Air realized that they could unbolt their chairs in their airplane and turn them around so that they were facing the patient at all times. But yeah, so we experienced that as well.
And given that preemptive information coming from the flight, we then also took out some additional medications for the room to have available when our patient arrived, as well as some soft restraints if we needed them. So it's always best to have that kind of proactive plan ahead.
Thank you. My question is, I maybe have missed it earlier, but how do you communicate? Do you have a voice Sarah inside your hood, or Is there somebody monitoring all of these communications and such?
Yeah. Well, it's kind of different in all of our places. So you get to where you're pretty good at communicating amongst your team. But we also used our telehealth system. There was a text messaging function. So not only could I see you at the desk, I could talk to you at the desk, and you could hear me pretty well, even through PAPR and N95 and all of the gear. But I also could, from the room, write, and it's just like a chat function, and say next time somebody comes back, have them bring this or that. So you get pretty good at it. And then also between the room and the doffing partner in the hall, some good sign language was done, and I know whiteboards were used to some degree as well in our spot.
Okay. So how do you maintain stockpiles of PPE with limited funding? So on tails of that is, how do you maintain the readiness, interest in years when there's nothing going on and attention is diverted elsewhere, and very limited resources? So.
I'll just mention briefly on the PPE for training, our staff for all those years, they would have, when we were doing PAPR training, they had a hood that had their name on it and just put it in a cubby that had their name on it. So everybody just kind of reused them and the TIChem suits and, everything else that really became PPE with the exception of, we gave them new N95s and things like that and gloves. But people got good at just reusing stuff for training. So I think that that's something we should be doing anyway. And we continue to do even though we have available supply. So that's a little bit about PPE. And then the sustaining kind of readiness piece is very difficult. To say the least, but I think whatever you can do to really engage your team members in things that are meaningful work, whether that's kind of turning them into a trainer, setting them loose, out there and doing some of the PPE work, maybe some outreach, maybe some tours of your spaces, maybe getting involved with your healthcare coalition on a local standpoint and kind of bridging together, maybe even pulling your teams together to do training as an entire island group might be a way for them to kind of engage with others and really work through some of those things. But it has to be meaningful work, so keeping them updated on the new things that are emerging out there, whether that's via an email distribution list or an occasional seminar or module that our physicians put together routinely. New information, that's all very helpful to keeping them kind of engaged in what's going on. But really getting them involved in those SOP developments and protocols and things like that so that it's really meaningful work would be my suggestion.
And we talked about this for quite a while, obviously, in my session, and I suggested that bribery was a good thing, whether it's with food, extra pay, extra recognition. How do you incentivize anybody to do something without compensation? You have to be creative. So it can be tough sometimes, especially when it's dull.
So the PPE stockpiles, do you guys maintain PPE stockpiles, rotate them through? How do you assure that you have the PPE you need when you need it?
And I kind of mentioned a little bit about that with our incident command structure, but I actually have a liaison with our supply management team who actually helps me with that because that's their expertise. And so we have ongoing back and forth information about what are our number of days on hand of this or of that. And we know that when we activated, we were using roughly 35 to 40 sets of PPE per day. So then just sort of doing some calculations in your head about what you need to kind of keep on hand. And then obviously for us too, I wanted to keep enough on hand to be able to do outreach and some of our work through some of our grants as well. So that people could actually touch and feel and do the training. So we've got quite a few days on hand of the PPE at this point. And certainly amongst our coalition again, we would move things around wherever needed be. The other thing that we found was we've had a recent MERS person under investigation at another hospital. And so truly met the case definition, was critically ill, young man, So we reached out and said, you know, what can we do to help? And so over the phone, talking them through those sorts of things. So hopefully you can kind of build that camaraderie between yourselves and maybe even between your island and others as those needs come to be when you have things like that evolve.
You know, I'll share a couple of observations. It's very hard. I think what Sarah's alluding to is it's hard to maintain an effective, up-to-date, non-expired supply of material and equipment if it's not used for anything else. And there's a lot to be said for thinking about PPE for these special uses that overlaps with the same equipment that's used elsewhere in the facility so that you can rotate it through, but more importantly, so that your staff are accustomed to using it. Being faced with a whole new set of kit during a crisis is not helpful. And so, you know, thinking through how that balance can be achieved is worth having a conversation with materials management and others. The other thing I'll say is that facilities don't have control of PPE supplies, right? You've got what you got, but if there's no more coming in the loading dock, you have a problem. Knowing how much you need, what your burn rate is for different types of patients is one piece of it. The other piece is relationships with purchasing organizations, right? Large they tend to be regional. And that means that if they know that you have a special need, they can prioritize flow. Some vendors and manufacturers also do the same thing. And it's probably worth a conversation incorporating sort of the state planning groups about how that's going to work if you're going to try and maintain this capacity. Because when push comes to shove and there's a national thing, everyone's clamoring for the same stuff. And you have the additional disadvantage of transport to get it here. And laying that groundwork makes a lot of sense.
Invite Chris to talk on that. He chimed in from AHA.
The Hawaii Healthcare Association.
I mean, for us, since SARS, we had the advantage, we've been stockpiling, and so it was a big advantage for our preparation for Ebola.
Actually, Chris, can I ask you to get to the mic? It's for the benefit of the recording.
How's that? Is that better?
So it's Chris Crabtree from the Healthcare Association of Hawaii, our coalition.
So we had stockpiled, you know, all the things that we needed. We asked the hospitals and other facilities to ensure that they at least had a start, you know, stockpile on end, and then we would resupply them. The challenge that we're running into right now was the August change with the CDC guidelines for PPE, which just upped it to a Thai Chem versus what we have is Thai Vec. And so right now we're just in the point where we had the stockpile, now we have to start over again. So that's just where we're at right now.
You want to comment on the Thai Chem, Thai Vec? Sorry, put you on the spot.
With regard to different products of that sort, there's clearly no clear evidence saying that one works better in real use, right? There hasn't been enough of a track record of either. But it does boil down to perception. And so if you have concerned individuals working with you who read that Thai Chem is better than Thai Vec and they want the best, you can understand why they would. And so many of the reasons for supporting one thing versus another is to just take that issue off the table. I think that if you have an appropriately fitting suit, then either one should do a very good job. We use both. In African settings. We also use plain surgical gowns in African settings. So there's nothing magic about one designation or another. You will, however, if you try to just pick one and there's like a higher level thing available, run into union pressures and other groups that really want to use this as a thing to emphasize. It's not always related to the effectiveness, it's more the perception.
One other comment about kind of suppliers out there. In this last year, I had some pretty heated conversations with 3M about moving from the 1870, which was in the Strategic National Stockpile everywhere across the country, because then we went with that so that we could easily adapt if we needed to get into the S&S. So they decided to move to the 1870 plus. Okay, what's the difference? Well, it's more comfortable. Well, who cares, right? You know, I couldn't see any real material difference in the mask, to be honest. It had gone through all the testing and everything, but they were just adamant that they were getting rid of, stopping making the 1870. So when we talk about stockpiling too, so you're going to be up against challenges like that, probably doesn't matter what vendor it is. So you're trying to do the right thing, but then you meet all these roadblocks. With the N95, I agree with Dr. Bell on trying to think about things you can use for other things. But when you look at N95s and stockpiling N95s, for anybody who's done a little bit of stockpiling, it's probably 20 years worth of what you would use for TB patients, right? So it's still going to be hard to rotate the N95 adequately to have any sort of a stockpile that would do you well in a crisis. So.
Yeah, I'm glad you brought those points up, Shelley and Mike, because that actually, Toby Claremont, who was with HH before, he and I used to talk about this, and I've talked about this with the preparedness staff about our experience during the pandemic. For those of you who don't know, we looked at the Strategic National Stockpile for PPE and found to our dismay that a lot of it was not what you all were used to using. So, I think what Shelley's pointing out is we all have to think about being flexible because it won't necessarily, and I know many of the hospitals, if not all the hospitals, are using pretty much similar types of PPE for the purpose of trying to make sure that it aligns with some of the things that are being stockpiled on part of HH, but with the, funding is tight. And as Shelley mentioned, it's why the state, we moved away from actually using our tight funds on stockpiling because one, we couldn't find storage for it that didn't get molded. And two, the likelihood of using it before, for anything, before it all expired, I mean, we already had bunches of things that were expiring and then we have to throw them out and it just didn't make sense. So from the state perspective, I can tell you we're relying on the strategic national stockpile, the national stockpile, but it's not going to be enough for every single thing out there. So I think, and like I said, there's no guarantee that what's in the SNS is going to be what you're used to using. So keeping that in mind, it's always, I think, what we're dealing with in these issues, it's always about being adaptable, being flexible. And Chris, you want to add to that?
Yeah, one of the struggles that we have with that, though, is the liability piece. The CDC comes out with guidance that suggests that ASTM 1671 or 1670 is what you need to go with. And then we just say, well, this is all we have. We're just going to go with this because it seemed to work for some facilities before. I have a big liability issue. And so can you guys maybe talk to that?
So I can't take away your liability issue.
Right.
But that having been said, there are some issues, not particularly with the Tyvek-Tychem piece, but in terms of permeability. It turns out that industry standards for protective equipment are really loose. Just like with N95s, it's just the filtration, not the fit or effectiveness. And with permeability of gowns and similar material, we're finding that there's a lot of permeable stuff out there that really shouldn't be. So the reality here is that the field, the manufacturing field and the regulatory field at FDA have not caught up with sort of a more mature level of need. FDA is pushing the manufacturers to tighten things up. I kind of like pushing the envelope a little bit because at the end of the day, I don't want to have this discussion again the next time there's something bad or scary happening. I would much rather have dealt with it here and said, no, anything that you're going to use for barrier precautions in a healthcare setting need to be at the standard full stop. It does create the problem that is very real, which is you got this old stuff that you can't really feel great about using. And that is bad. I don't know how to fix that wasteful piece. The other thing that I'll toss out there is conversations with Stockpile about the specific needs of a population. And what I'm thinking about is fit testing and facial fit for different parts of the country. What works in Japan, where I'm headed tomorrow, does not work well where I live in Atlanta, just because the anthropomorphics are so different, right? And I wonder about the Stockpile and whether they're thinking about that from a regional perspective, because I have a sense that the workforce here might need something different.
A mix, a real mix. Any questions from the audience before? Otherwise, I'll take from Okay, mull it over. Okay, what barriers did you face? Does anyone know from that group what kind of, all barriers, or was there a specific thing in mind?
Elaborate that. So that actually came up in our breakout, and it was a question that we posed to ourselves about barriers to readiness here on the islands. And I think that the top two that were identified for potential discussion were training, and training at basically two levels, one being the facility level, and I think we've addressed it a little bit in terms of maintaining readiness and trying to maintain and engage staff. But the other was more from a public health standpoint, as I recall, in terms of training the various public health entities or offices on the outer or on the other islands, and how they work together with your group and with the hospitals as well. Hopefully I've adequately reflected the conversation that we had, and I'm not sure, maybe that's a question for you, Sarah.
There are many, many, many barriers, I think, in government processes. Some of us were talking about earlier, the government process, you can't rely on the government processes. I think all of you have realized that by now. And I hate to say that, but it's true. And so that's why we have something like this, where we bring everyone together, because here in Hawaii we realize that relationships matter. It's frankly how we're going to get something done. If we don't all know each other and keep in contact with each other, I'm hoping that this is just the start, or even, it's not really the start because we've actually started this conversation a while back, but it's that we continue this process, we keep going with this. I'm hopeful that as long as we continue to get some federal funds, if you can whisper in the ears of those preparedness folks. And by the way, this conference is made possible because of Ebola supplemental funding for our and laboratory capacity grant funding. And so as long as we continue to get that kind of funding, I can tell you that we'll continue to try and hold forums like this to help you guys, because it is such a critical thing. But I could go on and on about barriers. But,
I'd like to add, for us, really it's COOP, continuity of operations, in that having 3 deep. If you're not there, your backup's not there, someone else needs to be able to pick up, and with all the acting that, when I'm acting, something happens, I don't know why, but, you know, and I'm immunization, but yet I'm dealing with MERS or SARS, you know, so that continuity of operations, which needs to be updated, maintained, and we have a lot of staff turnover. We have an aging workforce, so our institutional knowledge is about to go out the door with retirees, and so we have a severe nursing crisis. So again, it's a matter of making sure that that institutional knowledge is passed to the younger generation of the new workforce who may not have ever experienced any type of public health emergency response, never seen a communicable disease because they're so young. You know, double-edged sword of vaccines and all the, you know, great efforts being moved, you know, with CDC and other medical miracles in the past century or so. I also wanted to talk, we brought up at our breakout session about you need to do those full-scale exercises. Who you thought would have been ideal for this position in an emergency response, just because their title in a day-to-day operations is this, may not be the best person that you thought in a public health emergency response. And so you need to practice that. Tabletop is great, but also full-scale if possible, because then that's where you can weed out all the shortcomings or oversights and, you know, address it and alter it. And the issue of not being flexible, it's mentioned in different presentations in that, yes, you have your standard operating procedures, you have your protocol, there's the ICS that we've been trained, but not all emergencies go as planned. Your plan has to be adjusted, you have to be flexible. And so there's some barriers with some staff saying, well, this is what it says in the plan, we have to go by this. You need to follow chain of command for communication. Well, if I'm needing to get a runner right now, I have to go through my ops chief to go to the logistics chief to get a runner. Can't we just have the runner placed under my unit? We're just delivering vaccines. So, you know, this avoids a lot of delays. So those type of adjustments and flexibility to deal with a lot of these barriers.
In our infection prevention breakout session, we talked a little bit about barriers to training and how hard it is to even the quarterly PPE training and to stay on top of that. So we had a couple of individuals and it was great, and we were talking about train the trainer courses, and truly if we're going to have this infrastructure that's resilient and prepared, and we continue to move forward to really work hard on whether that's reducing healthcare acquired infections or assuring that we're ready for things like this, then can we use models like train the trainer, use the clinical educators within your organization to just kind of think about those key positions, key roles that you could train, and then they can train, and bring them back together once a year for a refresher to make sure everybody's still on the same page and doing things correctly in a competency related thing, but trying to really spread that wealth as far as who can train and how they can train, and give them the tools to do that.
Marion.
Marion Mellish, I'm a hospital epidemiologist at Kapiolani Medical Center. I have a sense of unease at this point. I think that we know where to find the ideal protocols. I think we can train people, but we do not and will not have containment units. They will have to be ad hoc. We do not and will not have these advanced systems for disposing of marvelous autoclaves that will actually work. So our problem is really going to be how to take the ideal and use the interpersonal procedures that we can access, but to apply it to our settings which are going to have much less technology. Even things like buying and maintaining some point of care testing or some hematology machines that we could then put in a dedicated place away from the clinical laboratory is going to require investment. And I'm feeling quite uncertain about how to actually get the funding and the buy-in for the kinds of things that I think we need to raise ourselves to halfway to where you are with. And then we also may well have a respiratory, rather than a wet type of patient. So I think I'm inspired to do a lot of the training, but I'm worried about the facilities.
Yeah. And I think, your points are so well taken, and I think this is exactly what we're hearing as we're kind of stopping in across the country and doing these visits. I think also we need to really be mindful and think through some of the equipment that we get, like the lab equipment. How can it be used in your day-to-day work? We've got ventilators through grants that we've gotten, and in some places in our community, those are in a warehouse. In our building, they're being used every day. So I think, as we buy equipment, we need to really think about how can we apply and use them in our day-to-day work, knowing we may have a rare occasion that you need to pull them out because the controls are very expensive, very time-consuming, and all of that, just takes a lot of energy and wherewithal. And then I think what we've really been saying too, and I agree, we don't want everybody to have fancy setups and things that are to be able to handle, whatever comes your way, but we want people to just really have the ability and the tools to be able to care for somebody for a short period of time in a safe manner. And those are things we do today when you have an exposure, whether that's a chickenpox or a measles or anything like that you're dealing with in your organization. So it's really kind of just taking these principles and applying them to everyday life. I don't have a lot more that I can say, but I truly empathize with what you're saying.
I'd like to say one of the biggest problems.
Matt, can I ask you to go to the phone? The microphone over there, so we can record you for posterity.
Great, that's what I need, posterity. Okay, so one of the biggest problems with having that equipment used somewhere else, okay, is not the fact that you can state that you decontaminated and you're quite sure that there's nothing wrong with it in terms of spreading any infection. It's the manufacturer. They will not touch it, okay? They will not come in, they will not do anything with that equipment because to them it's a liability for whoever comes in to perform the preventative maintenance. And depending on the cost of that equipment, I mean, if you use a biofire instrument, it's $55,000. They won't touch it. You have to get a new one.
Yeah, so that's definitely something that we have experienced and had to navigate. I don't think it was the biofire. Was it the Piccolo, perhaps? But yes, there was a really prominent press release put out while we had a patient in the unit about the Piccolo, and that it couldn't be serviced, and if it was basically saying that it was a single use for an Ebola patient. And
right.
I guess I can't offer you any clear solutions. I can give you the anecdote of how we handled that, which was essentially the head of our pathology and microbiology group that also oversaw our public health lab reached out to the CEO of that company and let them know what problems that was creating for us and was going to create for us as soon as we were done using it for that single use. At least in that instance, the CEO overwrote that policy for their company because it was a lower level individual that oversaw their protocols for preventative maintenance that initiated that. And the CEO understood that with the national crisis and global crisis that was going on, that wasn't the posture that their company wanted to put out. So they reversed their course. Again, this isn't going to always be the case, and I don't espouse that this is the solution in every case, but that's the anecdote to how that transpired for us. We definitely did experience that. We are acutely aware of that, which is also part of the reason why we've taken on a lot of those aspects ourselves. So for some equipment where the manufacturers come out and said, well, we're not going to put out an SOP for how to clean this piece of equipment to put it back in reuse in this instance because we don't want you to. It's going to have to be burned and reused. So that's where we assemble a team that evaluates the risk, evaluates the how we can adequately disinfect it, and it's a very interdisciplinary team, and we develop our own protocol for how we will handle that. Now, whether or not the company will certify that piece of equipment from that point on is definitely an issue, but like many of the things we've discussed today, we've taken that on ourselves. For instance, back to the PPE guidance, over the course of 2 years, there's been probably 7 or 8 iterations of that PPE guidance that's come out from CDC. And what's happening there is they have a very large group of people with a great deal of expertise that they're working through to develop, based off of the latest information, what they see is the best adaptation of PPE. There have been times when we've been questioned pretty heavily about not having protocols that align with PPE guidance. And early on it was that our PPE guidance for our providers was more robust than what current CDC guidance was. There was a point where OSHA was drafting guidance where had that guidance gone all the way through clearance, we would have been well below what the guidance came out. So the only answer I can give is to be incredibly active and to take on as much ownership of developing the rationale for how that is done at your facilities as much as possible.
I think this is also a situation where if there are instruments that you've been told by your local folks or vendors that we can escalate or we've worked through already, we can maybe help from a NETEC perspective in that regard. Because at this point, I don't know of any of our instruments that are single use. And they're all the ones that we were talking about that would be needed for an assessment hospital.
And I think in reality, what the issue that you're raising is kind of the opposite. What you're really trying to do is justify the cost of acquiring a piece of equipment that you would then use in a biocontainment situation for short term, and then using it on a daily basis. And I think that that's really what we're trying to see or say up here is that, finding, whether it's your PPE, whether it's your point of care laboratory testing, if you can find an everyday use for those items that are then available for you in case of an emergency, that is going to be the most cost-effective way and the easiest way to get that through your administrators. And Dr. Bell said a little bit ago that CDC in the field has used surgical gowns I mean, I think that, you probably will always have surgical gowns in your hospitals unless you don't do surgeries. But, and so I think that in a pinch can be used as barrier precautions. Now you've got to do something else to figure out sort of the bottoms of your legs and your head and your neck, but that is a possibility.
So I just would comment for all of you that if we ever run into this kind of situation, we certainly ran into some situations during the pandemic and other times. I can think of our functional shortage with antivirals and even the PPE shortages. That's where this relationship that we have with you, healthcare and public health, is so important, because as soon as I hear those kind of things, I'm bugging the hell out of the federal folks and saying, this is a situation here in Hawaii, it's not tenable, and I can try to do my part to try and ring those bells. I may not have authority over a private company and whatnot, but I can make it so that on the public health side, at the federal level, they're hearing about it, it gets known, and there could be pressure, they can help bring pressure to bear if it's making it untenable for us to take care of patients. I lost my other train of thought, but I think, in terms of investing in things, just want to talk about some of the experiences that Mike and I saw during SARS. We were out in Taiwan together, and they were going 9 yards, I swear to God, in terms of building these containment, remember? These, like, they were converting, those containers on trucks and stuff. They were using them and converting them into containment units, and these were going to be their negative pressure units, and like so many facilities and whatnot. And I can tell you, all of us on the team were like, what are they going to use these for afterwards? They're going to, and I don't know whatever happened to, I bet a lot of them, I kind of heard rumors that a lot of them just got demolished or got turned into something else that was never a healthcare facility after that. And just the amount of funds and resources that were put into those. So I definitely don't advocate for that. And with my group, we were talking about the fact that, you need to think about alternatives. And even if everyone has shown this is going to be our containment sort of area for the one patient that we have. And what if you get two? What if that containment unit is being used for something else and everyone's full up, and you really have to be open for, another patient? Where's your alternate? So, and no one can afford to have, we've heard that from our guests here, no one can afford to have a unit, to have even one bed in Hawaii on a given day. You all know that several hospitals are usually on divert. Our EMS folks know that very well. So just keeping that in mind, how do we use what we, keep it in practice? And it goes to what Mike's been saying, is that the goal is to make it so that this becomes sort of second place routine for us to practice infection control, to use some of the, a lot of the materials, if not most of them, to have sort of the facilities in place, and to be able to, but have plans, have practiced it, so that we can flip on a, dime and say, okay, this is going to be what, and that takes a lot of time and planning, and also buy-in from the C-suite. I was going to ask our folks, how did you get the C-suite involved if they weren't already involved? I don't know, Marion, I didn't want to jump in there.
Well, I just want to say that I proposed to our administration when we had the H1N1 outbreak, which was really very intense in Hawaii, and that we needed a unit. Now, we were already full all the time, and we have people staying in the emergency room for 3 or 4 days because there's no beds for them. So I said, why not have a 14-bed swing unit, so that that's where those extra kids can go. It can be properly done. Why, and then when influenza comes, we've got it. Well, years have passed. New hospital is being built. There are supposedly 14 beds, but they're not going to be any net gain. And so we don't really have that place. So then we have things like, well, we closed the surgery center, and that's where we put the influenza patients. So we're just talking about people who really need good infection control, altogether cohorted, and it's been very difficult. So as an advocate for this, I've gotten nowhere, and it seems so logical. I really like to know how everyone else is dealing with that. I know that we are supposed to be very tight on beds so that we don't raise our medical care costs and have unnecessary hospitalizations, but we've gone so far beyond that. here that, you know, we just don't have enough room.
I think the other thing that if we were in a situation where we had a tremendous influx of infectious disease patients, a lot of other things in our hospitals from a daily operations perspective would stop. So granted, the last thing you want to do is stop surgery procedures and things like that, but if push came to shove, I think that's probably all what we would decide and divert the beds away. So I kind of get the C-suite decisions on some of those things, and it's too costly from a real estate perspective to have beds that are sitting idle. So it's kind of just coming up with what are those plans during a surge to be able to accommodate an influx. So maybe even putting that in writing, you know, that we would negotiate, you know, stopping outpatient elective surgeries, we would do this, so that you have that kind of plan in place. You know, for the 9 years prior to activating, our unit functioned on $18,000 a year. That's what I got through grant funding to maintain the Nebraska Biocontainment Unit. So we talked a lot today about how to sustain readiness and what does that look like. So really thinking about, again, just-in-time sorts of things, whether that's a checklist, whether that's a medication list, whether that's a supply list. And the one thing that I never gave up on, or we never gave up on as a team, was getting together quarterly to do that drill. And so that was the common touch point. I only did 4 a year because that's all I could afford. And as long as I kept my expenses to a point that was reasonable and appropriate, and I could always say to them, you know, the space can be used for many other things, and so we always have people in that space doing various things, whether that's education, whether that's competency, whether that's training for various things. In fact, last week we had about 1,000 people through there for supply management, new cabinetry for them to touch and feel and look at for the organization. So how do you make sure that you continue to use your space in a way that's supportive, but do it in a very efficient manner? And a lot of that's with just-in-time kinds of strategies. So, but you can't give up on the quarterly training. That's just going to have to be something that you push through and really do the train-the-trainer model for your PPE and things like that, and kind of spread that wealth around amongst your team. So,
Marshall, you want to comment or?
Yeah, so 2 things. Shelley's being modest. She's how we kept our C-suite at the table. I think you got that probably from what she just said. And then I would just reiterate the cliff notes of what she said, which is even when there was very limited funding, in fact, I remember one leadership meeting where we all walked away because our $18,000 looked as though it was drying up and it would no longer be around. And so the one thing that we never budged, even if our whole leadership team was going to have to volunteer the time to make it happen, was just that, making sure that the personnel training and the personnel readiness stayed where it was, even if that meant we didn't have all the fancy tools and equipment, and definitely no construction projects to make our physical structure improved beyond where it was. So, I mean, you guys are already doing that. You've already identified the value of, or the highest value point, which is just that it's your care providers and having them trained. And there's plenty of studies and research and reports out there that there is areas for vast improvement in infection control and kind of that vigilance around things of that nature. So that's kind of always where we drew the line, that irrespective of funding, that was never going to go away. And I know that that's not an optimal answer, but I think that it's clearly what you've done at your facility, having just walked through it, that you've focused in on what is at the front line most important, which is having staff that know how to operate.
So yeah, I'm going to comment now, and I think one of the things that our friends, or my friends at Nebraska, have done well is when they've done some of their drills, they've invited the press in. And, you know, that's kind of like free publicity. And if you can tell your executives, look, we just got some advertising for you that you didn't have to pay for, you know, that may, you know, for Children's Hospital, maybe it increases your donations. because people love to give to children's hospitals. And it's, I think that, I have a different talk in terms of our experience and the media. And, we, in terms of the news coverage, if we had to pay for the news coverage in terms of advertising, it was over $100 million that we would have shelled out. And so it's those are some of the things that you can try to twist some arms of the executives to free up a little bit of extra funding.
Any other questions? You do have a question.
Hi, so I've got a question that's kind of near and dear to me. It's also up on the board, but whatever.
Hey, wait a minute.
So do you feel that all this EVD preparedness has changed regular infection control practices or even impacted HAI rates in your facility or Dr. Bell across the nation?
Yes, it has changed infection control practices in our hospital. The nurses that are involved in our units have become incredible champions of infection control practices on their home units. Some of these units have really high rates of CAUTI, or catheter-associated UTIs. And so it has done something to improve it. I will tell you that the biggest jump in improvement in hospital-acquired infections is when CMS said, we're not going to pay for them anymore. They got a different name.
I would echo what Dr. Lyons said. So for us, because I have infection control too, obviously CAUTI, CLABSI, all the kind of things that we look at from an infection prevention standpoint on a monthly basis, day-to-day basis. So some of our staff actually said, Shelley, I think it's about back to basics here. You have nurses training nurses who really got taught poorly on how to put a catheter in. I mean, who knows if that could have a lot of impact, but we had our first month with no CAUTI in a 600-bed hospital last month. So right after we got done with all that training. So it's, again, just kind of, utilizing your experts and your teams to really think about how can you apply everything that you're doing on a much broader scale. The hand washing in our small breakout group, we talked, and there were a couple of frontline staff here today and really talked about how they're being the champions on hand washing. Because without those horizontal measures, we aren't going to continue to make a difference in the healthcare-acquired infections either. So we can do a lot of fancy things with coated catheters, but if we aren't doing the basics, then that's just a lot of money spent for nothing.
So, yes, the third yes. I think that the experience with Ebola in the United States brought people an awareness of the concept of infection control. I think that in healthcare and across the general community, it had faded away. We started talking a lot about quality, right? We started talking about metrics of this sort and that, and they're important things, don't get me wrong. But the idea of preventing the spread of infections had kind of faded from people's minds. I think that this experience brought into sharp relief the fact that infection control is a very important tool, and if you don't have it when you need it, bad things happen. That certainly has helped me talk about healthcare-associated infections in a very concrete way, and not in a mean way, but in a definitive way, pointing out that we as a nation can do some improving, that we're not perfect by a long shot. I think that has been very helpful, and it's a sobering but I think useful reality.
Questions? All right. I'm going to go to this side, and it says, how do you recruit staff for these stations? I heard that, situations. We heard that voice during some of the visits, and I'm thinking they just want to talk more about this, and because it's a real stumbling block, and you've all heard how this is a unionized state too, so there are a lot of union issues, and I know you guys aren't union, but I don't know what you've heard from colleagues in, say, New York City, where it is predominantly unions.
So I wish we could say that there's a magic dust that you can use or something like that, but I think it truly has to be one of those kind of innate things that comes from, really individuals who are maybe those exceptional performers that and reaching out to them and having a conversation if you're struggling right now with getting team members, and what would it take and what is it about it that is worrisome to you, what are the barriers for you to step up, and try to just be more informed about what are those things within your organization. To kind of talk a little bit about the New York situation, I know in talking with our colleagues there, so they are union, and in their ICU, then all of their staff there are required to participate in care of these folks. So, you know, I think they've got a pretty great team. You know, I've heard several of them talk, and so I think it's an agreement they've come to. So their unit is actually based, their rooms are based right inside of one of their ICUs. So that's the team who cares for them. So I don't have any good answers related to that, other than I just think you've really got to just have some further conversation with some frontline folks and better understand what it is that might be the barriers for them, and see if you can reduce them. We talked a little bit today in our infection prevention group about eye splashes, and seriously, why would anybody not want to wear eye exposure? But when you kind of get to the bottom of it, do they have the right eyewear that fits in their pocket that they can keep on themselves, that they can see out of when they need it? So it's kind of just really understanding where people are at and what the situation is, probably.
Marshall, Dr. Lyons?
Yeah, I think I said it earlier that you just have to find the right incentive. And someone said yesterday, more carrot, less stick. But
I'll also just observe that people are much more willing to step up when they feel like they're really good at what they're being asked to do, right? When you know that you're a pro at something, it feels good to step forward and pitch in. When you're not so certain, you don't feel the same way. And so I think it gets back to not only identifying the leaders, but helping those leaders grow more leaders and empowering that.
Yeah, and I would just comment that I think Shelley said it the other day. It's almost, or maybe it was Marshall, you know, that if you make it seem like a status symbol to be part of this team, you know, you are the brightest and the best. We chose you, and there's a screening process you have to pass to actually be on this, you know, and there's a special name for you. I honestly think that might be a draw for some people, you know, because now you're recognized among your peers as this elite group. That might be something to consider. So, question.
Yeah, I don't know from you guys have the website. We have a lot of your SOPs and all that online. I was wondering, do you guys have listed the kind of like the burn rate for some of a lot of the PPE you use, so that way you could look for planning to like give to our leadership about if we were to get a patient for this many, this is the likely rate at which we would be going through supplies as kind of like a planning idea. What?
Yep. So if you go to needtech.org on that resource page, we actually just put it out there last week. CDC came out with a PPE calculator, and actually Emory in Nebraska tried, you know, very early on during when we activated, we helped them with a lot of the scenario-based things that are in there and building the Excel spreadsheet. I think Sonia built the Excel spreadsheet, and Sharon and I did the different scenarios, which again, if you guys remember, as we've met with you all and kind of visited through our walkthroughs of your facilities, some of your PPE burn rate is going to be based on your patient acuity, your geography of your unit, how far things are away from each other, what your shift hours are, where your lab is, you know, lots of different things like that. So it really does a good job, I think, of walking you through what are all the potential situations you should be thinking about, and then is it a one-patient model versus a two-patient model, and what changes in your staffing ratio for that, and then what does your PPE, what kind of PPE are you using, and it really helps you. I've got a student right now who's actually working through the calculator to see if it does what we hope it does. So we'll see on that. So.
There's some great opportunities, I think, for student projects and interns and things like that who might be interested in you to, why not use them? I know we get queries from UH students, HPU students sometimes for things, and this might be something for you all to take advantage of, maybe among the med students. Some of them are looking for projects too, so something to think about, to utilize. Let's see. Oh, we went through all of them. Oh, one last question here, I think, and it's kind of along the lines of what you all have been talking about, or what we've been talking about, but how do you change the existing culture as a whole to lean forward and be a prepared culture? I think that's something for all of us. It's a challenge.
If I were you, I would go back and I would talk about what happened on Guam. And, and unfortunately, put Guam out there as an example and say, we've got, so many visitors from around the Pacific Rim, and, look what happened there, and if we're not prepared, then it could happen to us. And frankly, I couldn't go, but I think Bruce Ribner, our director of the unit, did go. We were invited to go to Korea because, frankly, they felt that they did a very poor job with MERS. And there was a government inquiry as to the response of Samsung Hospital to the introduction of MERS there. And they wanted our expertise. And I think that, it is, we have these interactions, but yet a lot of, especially China, is not very forthcoming when they're having problems with epidemics. And so it could land on your shores. You're one flight away from it. So.
There's also some really good websites and things, not only the CDC website, but it's what is it, John? UPMC. They have a daily email thing that comes out and kind of talks about the threats in the world. And I think also adding some transparency to a few things like that when you're talking with leaders and others in your organization could be really helpful too, just so that they know that we're not just this isolated group, that nothing's ever going on. There's a lot of stuff that happens every day out there. And so just picking and choosing a few of those things to continue to escalate within your leader groups as well as within your teams can help, I think, to keep it real for people.
And Annette, you want to talk about Guam a little?
Another resource was the ProMed mail that was brought to our attention right before the MERS incident happened, in addition to PACnet with their interactive map of emerging diseases or ongoing outbreaks within the region. And Guam just happens to be surrounded by, there's dengue, there's Zika, there's, and so that's something that, we try and share with the various key stakeholders in our medical community. But definitely education would be my first thought. Throughout the community, throughout the government and all your partners, education is key to change that mindset because we always talk about prevention versus having to respond and treat. Prevention is cheaper. And going back to the Ebola, we were trying to do an MMR campaign because we had measles in the region, FSM, starting in late 2014 into 2015. People were asking us for the Ebola vaccine, but we were pushing the measles vaccine. So it's, again, it's that putting it out in the public that this is actually an urgent issue. It may not be on our shores yet, but it's a flight away. And so, let's take the preventive measures now, which would be, highly cost effective for us, cost savings, versus wait till something comes and then we're in a panic mode and chaos.
Mike, did you have any comments?
To instill a culture of preparedness?
Wasn't sure.
Well, I guess I would ask you in return, I have a hunch that the populations that live in Hawaii have a culture of preparedness. I don't think you can survive without it. Is that not true?
What do you think? Well, considering the fact that every time there's a hurricane, potential or tsunami potential, and suddenly there's a run on the gas stations and Costco is and all the shelves are suddenly empty. I think we still have some work to do, right? I think it's getting there. It's starting to, and maybe this past season of all the near misses with the hurricanes has started to get people a little bit more sort of aware about these things and the fact that we're having an ongoing dengue outbreak, and now we've had a congenital Zika case, unfortunately, sadly. I think it's much more and more in the forefront. But yeah, I think even in our population in the middle of the Pacific, far from everywhere, even here, we struggle with that.
The reason I ask is it always strikes me as odd to ask for a healthcare system to invest in preparedness in isolation, right? I mean, it really sort of needs to be a community discussion. It needs to be something that the entire population decides is important and that their leadership will support, not just from the C-suite of a hospital, but from the leadership of a community. And I struggle inside wondering how do we get this into popular conversation? We as a profession don't brag nearly as much as we ought to. We're not like pro sports stars. Maybe we should be. A little bit, not that much. But I wonder, how do you get the message of impact and value out to a community of voters, frankly, and taxpayers? How do we do this in a way that makes the concept, the conversation of investing in preparedness, in infrastructure, sort of a no-brainer and something that you're not bringing to the table for the first time?
So this is going to be a fairly pragmatic response to that, I guess. So one of my other hats is Director of Preparedness Training and Exercise Programs for the state of Nebraska. Stood up a Center for Preparedness Education that would, they used hospital preparedness and public health emergency preparedness funds to stand up that unit years ago. And so I had responsibility through that role for 5 years of healthcare coalition exercises. And when we initiated that, we had this mixed bag of facilities that made up those various coalitions. There are 6 coalitions that we focused in on. Mixed bag in terms of readiness and engagement. And the strategy that we developed, and I only am aware of this because speaking of graduate students, I had a graduate student go back through all of the data for the 5 years to see what our results were from a fairly practical standpoint. And we saw there were a number of coalitions that decided to get out of our typical tabletop and full-scale and small drill exercise process and engage in a functional exercise. And a lot of times we switched the terminology between full-scale and functional because we tend to look at them the same way. But the functional exercise as we conducted them was really focused on testing leadership. So when we typically do a full-scale exercise, the incident command may get activated just in time for the 3-hour exercise to be wound down, right? So we never really got the full opportunity to really take them through the paces of what they would be asked to do if we had a full emergency that went on for days. And this actually came on the heels of some full hospital evacuations that occurred in our region where CEOs had to step in and fulfill an incident command for 7 days as they emptied out their hospitals and really stretched them. So we used that to learn off of. But essentially, we went away from the typical exercise and we did essentially an incident command only exercise for 3 to 5 hours. We would write those exercises so that we'd pull out key people that we felt like were really the champions of preparedness and that a lot of people relied on. We pulled them out of the exercise mid-exercise, whether it be an infectious disease or a chemical exposure where it impacted their family, so they decided to leave. Over the 5-year process, we found that the coalitions that really embraced those exercises, that tested their leadership, I can't verify that we saw a culture shift, but we definitely saw a great deal more buy-in to preparedness. Their participation, the type of feedback that we got out of those exercises was very different from those that we stuck with our typical drills, tabletops, and full scales. And I'll never forget, so usually it's the executive team, right, that mans some of those higher level incident command things. So it was really valuable for them. And I remember we had a hospital executive that had demanded they be incident commander for their facility, and there had been some question at their facility. So we ran them through the paces. And I recall at one point we were running this simulation area. So when they needed to call CDC or transport, they called our group. And we told them what would or would not be available to them, which I think would be very applicable for some of your other islands. And they kept trying to just take the easy way out, saying, well, we need a chopper, we need these other things because we're full and we need to divert now, we need to move some of these patients. And by virtue of the exercise, we couldn't give them any of that. And this executive, we pushed them to their breaking point, right? To where I think they forgot that it was an exercise. They were fully immersed and fully stressed. And but that particular executive in the after action had learned probably more than anyone else. And I think going forward, we definitely had multiple backup positions to fill that particular role at that facility going forward. And again, they went from having 1 person designated to 3 people designated as a result of that. And of course, in the next year, we tested those 3 people instead of the 1. So that's somewhat anecdotal, but rethinking how we test ourselves, I think, is important as well.
Okay. Any other questions? Everyone's raring to leave at this point, right? It's been a long day. With that, I just want to express my appreciation for all of you who've stuck it out all day, and to our guests. I think I've learned a lot. I hope you have as well, and felt this was useful to all of you. I think we heard a lot of different themes: communication, 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 and not just that, but in communication not just with the lay public, but even within our organizations and our partnerships with the C-suite, engagement, I think, and flexibility, and making certain that the things we do are constantly in use, constantly practiced, and not something that's just sort of put there on the side and we just activate it when we need it. It should be something that's always in circulation, always in use. So, for Hawaii, I think, we're not going to be like Nebraska and Emory. That's a given, There's a reason why we're calling our hospitals referral hospitals and not the regional treatment centers. We didn't volunteer for that, and we're not that for the Pacific. But we also recognize we're out here in the middle of the Pacific. There is a very big likelihood that although we would be akin to the assessment hospitals on the mainland, and that would be the ideal, where we would sort of keep the patient stable just long enough to get them to the regional treatment center, the likelihood is that that patient may be here a lot longer because of weather issues, because of whatever, getting the plane off, or who knows what it could be. Maybe the patient itself, him or herself, is too unstable to move, and we need to ask for the expert support to come here. So, those are the things that we need to think of. The likelihood is that no one's going to ship a patient directly to us for the care, except for our own, frontline hospitals in the neighboring islands. And the truth of the matter is, most of them are going to rule out. It's not going to be a known Ebola patient or a known MERS patient. Those folks are going to bypass and go straight to the regional treatment center. So the likely scenario is someone walks into your ER, someone's brought in by a car, or a personal vehicle even, someone by the EMS folks, someone was found, or someone is airlifted from a neighbor island hospital with all their waste, by the way, and that they accumulated in the 24 hours maybe, or hopefully less to more like maybe 8 or 12 hours or so. And they don't have a diagnosis yet. We don't know what's going on with them. And the more likely scenario is the referral hospitals, you stabilize them, you hold on to them until we can secure the transport to the regional treatment center, which, by the way, we're really hopeful for Region 9 is getting close. California has indicated a hospital in Southern California, which is probably the best possible scenario for us because, as you all know, that's the shortest flight time for us. So that is great. But until then, and then really in talking, the transport, along the road, it's going to be a transport to the airport from one of your hospitals to the airport to get that patient off the ground and to the regional treatment center. So those are things for us in Hawaii to think about. And as I said, my hope is that we continue, even if the federal funding does dry up. I hope not. But, with the help from federal funding, I really hope that we continue this process, we continue to talk to each other. I hope we're able to continue one day, to have another conference like this, maybe with other groups of partners as well, and we just need to keep pulling together. So again, all the slides, all the talks have been recorded, are going to be available online. The links will be emailed to all of you. If you have any questions, let us know. Last but not least, I just want to express appreciation for my staff. Zishan, Melissa, please stand up. As well as Lisa here. So if you don't know already, Dr. Melissa Varay is my deputy state epidemiologist, and Zishan Chisti is our very capable healthcare associated infections coordinator, our jack of all trades. And Lisa Takauchi is our Council of State and Territorial Epidemiologist Fellow in HAIs. And so the three of them really have been instrumental, even as we struggle with the ongoing dengue outbreak. It's been pretty stressful, but that's just to let you guys know the level of commitment. We want to make sure Hawaii is safe, and we recognize the only way we can do that is we bring all of you guys together to talk about things like this. So thank you. Okay, aloha.